Okay, so we're gonna start as you all make your way back to your seats. What I'm going to do, the second panel is a case study using the California experience, and moderating that is Elwood York. And Mr. York is a Cochs board member and has a little more than 25 years of experience as a civil and criminal trial attorney and an appellate counsel. As the former director of pretrial services in Monroe County, he was responsible for drug court and other pretrial programs in Monroe County and the 16th Judicial Circuit. He oversaw and managed 16 employees and supervised over 700 individuals court-ordered to custody, and assessed and made recommendations concerning bond, release, electronic monitoring, house arrest and diversion programs, including drug court, mental health courts, and juvenile courts, on persons arrested in the circuit. Prior to directing pretrial services, he served in several capacities for the District of Columbia Department of Corrections, more recently as the interim director and the deputy administrator for secure programs of youth services, external confinement administrator, and chief of the Office of Internal Affairs, as well as the general counsel. So we will now begin panel 2. Mr. York, it's all yours.
Thank you. It's an honor to be here with this austere group. I think I'm here because I've either been hunted, held, released, or administered some type of human endeavor, working in D.C., the Virgin Islands, Texas, and Florida. On that note, I'm really interested, and I'd like to thank Art for saying something. Most people don't realize that jails have been releasing people and treating people since the first person got incarcerated. They're very good at it. And there are some things we'll bring up as this conversation goes forward, but I'd like to say that once Estelle was rendered by the Supreme Court, it changed jails and prisons forever. And there are individuals who actually go to jail to get health care. And that's a sad state of affairs for us at this point, but that's the best care. I think any jail administrator will tell you he has encountered people who have said, I got arrested because I needed health care. Just want to put that point out. As we talk about it, I think when you come to these functions, you need a practical case study. And today our case study is the California experience. The panelists that will entertain, inform, and confuzzle you will be first Stephen Rosenberg, the president of Community-Oriented Correctional Health Care, or Cochs as we call it. Mr. Rosenberg has over 35 years of experience in assuring access to health care for our nation's most vulnerable populations. He is currently the president of Cochs, and Cochs is a nonprofit organization that works to build partnerships between jails, local health care providers, with the goal of establishing medical homes for offenders in their communities. Cochs helps communities reduce the incidence of chronic disease and behavioral health disorders and the cost of health care. The next panelist is Patrick Duterte. He's the Director of Health and Social Services for Solano County, California. He is also the chair of the Subcommittee on Health Disparities and of National Associations of Counties. Mr. Duterte was appointed as the Director of Health and Social Services for Solano County in September of 2001, directing a department of close to 1,200 staff. He previously worked in Silicon Valley, Santa Clara County Human Services Agency as Director of Employment and Benefits Services. He has also managed child welfare programs and employment programs in San Francisco and San Mateo counties. After serving his country in Vietnam, Mr. Duterte received his bachelor's and master's degree from the University of California at Berkeley and San Francisco State, respectively. He also is a Bikram yoga practitioner, which means that he sincerely is always trying to achieve perfection. The next person is Mr. David Muhammad. Mr. Muhammad is the Chief Executive Officer of Solutions, Inc., and the former Chief Probation Officer of Alameda County. Mr. Muhammad is the Chief Executive Officer of Solutions, Inc., a consulting firm providing technical assistance to several California philanthropic foundations on juvenile and criminal justice issues. As Chief Probation Officer of Alameda County Probation Department, Mr. Muhammad ushered in reform to move probation away from a deficit-based correctional model into a strength-based positive youth development model. Mr. Muhammad previously served as Deputy Commissioner of New York City's Department of Probation and responsible for seeing over 35,000 people on probation and a staff of 800. He also worked in Washington, D.C., reforming the juvenile justice system there as the Chief of Committed Services for the Department of Youth and Rehabilitative Services. And I'd like to add, he really had a serious job. We both had the same job at one point. He used to be 6'8" and had an afro like this. And I used to be 6'11" with another one. So without further ado, I'm going to talk about the case study.
Thanks, Woody.
California's Bridge to Reform, closing the gap with Affordable Care Act. The Bridge to Reform came in June of 2010 when California submitted a 115 Medicaid demonstration waiver dubbed the Bridge to Reform in response to the Affordable Care Act. The waiver allowed counties in the state to expand their coverage for low and uninsured, the non-pregnant adults with federal matching funds. California's uninsurance rate, 7 million, is projected to decrease by more than half by 2016. The uninsurance. The state has extended coverage to low-income adults through what they call the LIP program. It took me a long time to say that because of the H, but it's the LIP program, which is Low-Income Health Program, and it's provided an option for each county to provide Medicaid coverage expansion to adults, health care coverage initiatives for adults, and what it will do is benchmark it at 133rd% of the federal policy rate, which in dealing with jails, someone else has said it, often the case managers are going to have a problem with that, and that's why his program is very effective. You can look at the graphs and see as the uninsured and the assured numbers move back and forth that the combination of the Hispanic, Latino, Asian populations are just tremendous. Just the graphic has to take you a moment and set you aback to see what is actually out there. The coverage requirements are this. The waiver funds for public hospitals to achieve a population-focused improvement included are low-income populations with chronic conditions, including mental health and substance abuse, conditions also common in the criminal justice population. The enrollees must be assigned to a medical home, and the medical homes actually enable the providers to develop some expertise and teams that help serve these challenged populations. The impact is obvious. The expansion will enroll a population that has had historically low access to mental health substance abuse services. In addition to potentially preventing mental health-related interactions with the criminal justice system, Medi-Cal expansion can also provide newly released prisoners with medical treatment, which could be crucial to reducing recidivism. Also, California passed Bill AB 109. This law became effective in October of 2011, and it mandated individuals sentenced for non-serious, non-violent, non-sexual offenses will serve their sentences in county jails instead of state prison. Now, for those of you who are in the county, you kind of feel dumped on. I know, been there, done that, but that's what the law. Many low-level offenders are being placed under the community supervision rather than serving jail time in order to make level for higher-level offenders that historically would have gone to prison. As a result, there are increased opportunities for the offenders to access health care in the community. I'm pretrial, Tim Murray somewhere in the back. I drunk the Kool-Aid for pretrial and diversion. So if I get into my pretrial thing, y'all just call me back. The Los Angeles County Low-Income Health Program, as of August of 2012, 204,000 low-income residents have been enrolled in Healthy Way LA. The estimated ACA eligible population in Los Angeles County, however, is over 600,000 individuals. That means that there are approximately 500,000 people who are eligible but are not enrolled. Mr. Duterte, you want to?
I'm first.
Okay, he wanted to do his thing, so you go right ahead.
So
go ahead.
Yeah, I just want to briefly talk about what we're trying to articulate here. So if we look at California now and the other two states we'll be looking at after lunch, I think the question becomes, has early adoption, has Bridge to Reform, has it really made an impact on disparities? And I think that we heard Ms. Robinson this morning say, well, we want it to. What I would say in LA County is certainly it hasn't yet. And I think the reason it hasn't yet goes back to the slide you just showed. We're not enrolling folks. And Kavita said it brilliantly. If I go down to the neighborhood the Twin Towers is in, to those low-income neighborhoods, there's no billboards, there's no internet sign-up. I'm not signing folks up in the jail. So the 200,000 folks who are already enrolled are basically the folks that are already patients at the county hospital and the county emergency room, just as Kavita described. So my message, which is a very simple and short message, is if we want to impact the disparities, the very first thing is enrolling these folks, okay? After they're enrolled, we have to have systems of care and everything else to take care of them. But if I'm running a 2-to-1 ratio of folks who are not enrolled, okay, that means that I'm not likely to impact the disparities in the CJ system. So that's sort of a threshold message that I want to get across. And then I guess we're going to have Pat and David talk about it from their perspectives. So with that, Pat?
All right, great. Thank you very much for having me here today. I really did question why they had me here because as people know me, I'm a troublemaker and I try to figure out ways to do it.
Which one of us is not a troublemaker?
No, all of us are troublemakers, and that's why we're in this business. But I did want to share with you a little bit about what's happening. The policies are made in Washington, policies are made in Sacramento, but the counties are the ones that actually have to deliver the services. So I want to talk a little bit about that. And I want to talk about our county. We're a small county, medium-sized county, 421,000. But I call us the Rodney Dangerfield of counties because we're between San Francisco and Sacramento, and so we get no respect. The money all goes to them, and we got to figure it out ourselves. So the partnerships that we have with everybody in our county is really important. I want to talk about 2 anecdotes about this partnership. I had a number, about 10 African-American ministers come to me, ask me to meet with them, and they were upset because what had happened is they'd been releasing prisoners before this AB 109 program came up. And they said, we've got people coming into our ministries, they have HIV, they have diabetes, they have, they're spreading sexual transmitted diseases with our parishioners. What do we do? And my first instinct is call me and I'll figure it out for them. But that's not systematically how you have to do it. And so what we did was the ministers actually got involved. They talked to their ministries and said, we need to do ministry work. We can't just come to church every Sunday. We need to do ministry work. And so now the Board of Supervisors kicked in a little money for helping organize these ministries, but they're going out and they're actually the navigators for helping people who come into their ministries and getting them into the right kinds of services. That's really important, and that's a partnership. The other one is that we had a hospital that was, people were showing up at the emergency room trying to get care. That's a lousy way to deliver primary care. And so we wanted to, as a community, wanted to have a primary care clinic in near the hospital so they can go to the primary care clinic instead of to the emergency room. We did it. We all kicked in dollars. We have 3 competing hospitals that kicked in dollars. The county kicked in dollars. Nonprofits kicked in dollars to build this clinic and have a federally qualified health center actually run it. It makes all the difference in the world. I thought it was a great idea until the grand jury threw me under the bus. They said that you're serving undocumented people. You should just cut them off and let serve everybody else. And basically, I stood up to the grand jury and I told them, bad policy. You've got immigration issues are one thing. I mean, you got to deal with those, but they're living in my community. I'm in charge of the health department. We have to deliver services and have a healthy community. Well, this got picked up. The grand jury and I just kind of went at it for a while. And I don't know why the Wall Street Journal picked it up, and the Wall Street Journal picked it, and the New York Times picked it up about this little conflict. But basically, it just showed where they do not want to deliver services to undocumented in this country. But the public health issue is that you've got people next to your kids making your food, all the things in your community. And basically my point is that you've got to lead. You got to do what's the right thing for your community. Now, let me just share a few things about this. And I want to just show what came up in the election. They talked about the change of our communities throughout the nation. It's shifting. This is the census from 2000 in blue and the census in 2010. As you can see, the white population is dropping, the Hispanic population is growing, African American is remaining steady. Now I want you to remember this a little bit because I'm going to go to what's happening in our prisons. So in our prisons right now, our African American population is 43%. And what I had shared with you earlier, that our population in the African American population is 14% in the county. When we talk about this, these are the kind of figures that are shown. Dr. Peckram has talked about this earlier. This is the kind of stuff that you hear all the time. But this in our prisons really demonstrates the disparities in the number of people, disproportionality coming into our prisons. Also, we were talking about the prison population, what people say that they wanted to realign low offenders to the counties because the counties can do it better. They gave us 35 cents on the dollar with what they were spending. Basically, they were getting overcrowded. They weren't delivering medical care, so they were getting sued, and so they wanted to send it to the counties because we can do a better job. Basically, I call it the shift and shaft. You know, we're taking care of it at the county level, but I still think we can do a better job. You can see that our county, when we started in October 2011, had about 750 inmates. Look at it now, 939. You know, it's a little bit of what Yogi Berra said, deja vu all over again. We're basically recreating what the state did. We have to do something different, significantly. There's hope. I really do. And you know, I hope. And I think the hope in counties is really the partnership that is being formed. We formed in California counties many years ago a county medical services program. 35 out of the 58 counties in California pooled their dollars together for indigent care. We're required to provide indigent care in the counties, so we pooled our money. 40,000 California recipients actually received those services. General fund, vehicle license fees, and sales tax would get those dollars. But initially, we used it for just catastrophic care and ER visits. My county, we really believed in managed care that you do the upstream work because you'll lower your costs downstream. And so what we did is we piloted a managed care program using a county-operated health system, and that's something I can talk about at another time. But we lowered cost, our client satisfaction, provider satisfaction, staff satisfaction that deliver the services were all above 90%. And then we hit our HEDIS marks, which are our quality marks. So we're doing something right. Now, with the agreement of all the 35 counties, we have managed care in all 35 counties. There's also ways to lower costs for jail inmates, and I'm pushing the envelope on a lot of these things because some people will give me the look like, what are you doing? But the 1115 waiver of implementing healthcare reform for indigent adults, in California we have 50% federal participation. Here's where I'm pushing the envelope rule, but I did hear this from our Health and Human Services Department. The Medicaid rules say you cannot draw down federal dollars if you have a person incarcerated, and it's technically behind the walls of the jail or prison. Well, this is something we're looking very closely, is lower your cost by providing health services outside the walls, and you can draw down, and it's playing games a little bit, but that's what you got to do at county levels. You got to figure out ways to make things work when these policies are running over here. Also, if you integrate healthcare, and this is what we did a number of years ago, is integrate psychiatric care, behavioral health with primary care, all in the same place, because they see their primary care physician, they see that the person's kind of going sideways. You have a behaviorist there to kind of take care of it now, because what happens now when a primary care person sees them with mental health problems, they basically give them a referral and they never make their appointment. So having it integrated will save you costs and do some upstream stuff. I'm not going to go into a lot of details because I'm burning time, but we have a plan for reducing recidivism in our county. You have to do in custody and out of custody continuum of care. You cannot just separate it out. Let them go, send them out into the world. Use evidence-based programs, a day reporting center when they're out in the community. And I hate the name. I'd rather say it's an opportunity to get your act together center, because we're putting all the services there. And I'm bringing, it was a terrible, why did I use this? My whole health and social services arsenal, that was a terrible thing, especially when you're dealing with prisoners. But bringing everything I have to the table, my mental health, substance abuse, my benefits programs, my public health, my HIV programs, bring that to the table. You gotta start integrating that with your partners. And then a new peer group for your inmates out there. They're coming back home and hanging out with the same people. That's a recipe. That's why California has a 70% recidivism rate, is you've got to find another peer group, people who are recovering, a new group of people that actually make a difference. Employment services. And then last part is really important, is that you have to have partnership and trust with all your partners. That means that you have the judges, the DA, and all those people, is that you have to hang together and sing Kumbaya together. You have to hold hands. You can't leave people hanging out there. That's just really important. Also, don't overpromise. We're going for single-digit thing, because each person who actually who gets reincarcerated probably commits 4 or 5 crimes or more. So there are impediments, and I'm just about finished here. There's a lack of split sentences, which meaning that the judges really tend to put people in jail for their whole sentence and not split it up between probation and the time in jail. They don't want to do that because they don't feel it's safe. There's no room for services in the jail. The fear of the judges and district attorney to release prisoners, and unsure if these elements will work despite the evidence that shows it does. And there's a real lock 'em up mentality. It feels good, but it doesn't help. So just the last thing I want to say is I really do believe it's a great opportunity. We can innovate and do really creative things with technology, but it's really pulling people together to make a difference in your community. And you can really have a healthier community and a safer community if you pull all the people together. So thank you very much.
So, Patrick, you just answered the question why I asked you to speak, because there you showed the numbers, which is the disparities are huge, and there you are as a county leader trying to figure out what strategies you need to affect it. So that goes back to our case study approach of describing it on the ground. That's on the health side. Now, David, you're going to tell us about it on the other side of the fence.
So I really want to make 4 quick points. I would love to get to some question and answer. And One, just some clarification on criminal justice realignment in California, because it's an incredibly confusing, hard to understand thing. And so what the state of California did, because it was 170%, I think, of capacity in state prisons, and the Supreme Court said you have to get down to 135%. They didn't say you had to actually get to capacity. You just had to get down to 135% capacity. And the way they did that is saying people in state prison who are there for nonviolent, non-serious, non-sex offenses, lower level offenses, that when they get out, their normal release date, there was no early release. I got a lot of media calling me on the October 1st, the day it hit, saying, where can we send our cameras to the buses, you know, the big, massive, there was nothing like that. It just was whenever they get out for their normal release date, instead of being supervised by state parole, you're supervised by county probation, whatever county you're being released to. The second part of the law says that any new convictions for a nonviolent, non-serious, non-sex offense, unless you had a prior serious offense, you can't go to state prison anymore. You only can go to county jail, and you get one-to-one, day-for-day credit, 50% time, good credit while you're in that county jail. And the third thing it did, it says parole violators can't go to state prison. They only can go to county jail. California was full of, their prisons are full of violations of parole, right? So that had a significant impact on the population of prisons. The populations of their projections were short of what happened. The reduction has been even more significant, though we're seeing a little bit of an increase in admissions now. There was a deep dive, and what that did was, and as I said, so the policy, it was good, because lower level offenders shouldn't be in state prison anyway. And we're mostly talking about drug and theft crimes. That's the vast majority of the offenses we're talking about. And we're talking about a population who's largely drug addicted and who are getting prison. And California has consistently said we want treatment over incarceration, particularly for the drug addicted, and passed Prop 36 to do that, and then it was defunded. And so what has happened, though, is, as we were talking about, is the funding. They gave us 35 cents on the dollar of what the state was charging, but said, counties, you can do it better. That is very true. Counties can do it much better. And I argue we are doing it much better, even with the 35 cents on the dollar. It's just created some crisis in counties that were over-incarcerators. Where in Alameda County, the increase in population has been 100. Right, in a county much larger than Solano, which its increase has been several hundred, and we have so few inmates in Alameda County jails that we don't even need to, we can close one of the jails. But it is still a significant challenge. In the first year, we got $9 million. And I cried and screamed and said that there was the funding formula was fundamentally flawed. And so for the second year, Alameda County got $29 million from the state to implement criminal justice realignment. The problem is almost the entirety of that money went to the sheriff's department. And so this whole notion, the spirit of the law is that these folks should be getting treatment and rehabilitation in the community, not needing to be incarcerated, which is the most expensive option. And so just want to make that point. I can go on and on and on. I'll try to stop. So the second part is Alameda County's LIP, the Low Income Health Program, which is called Health Pact. And so what Alameda County is doing is what you just said is, when inmates in the jail go into residential treatment, we are billing Medicaid. Right, Medi-Cal, because California turns everything into Cal, and so that's happening already. I was trying to get some information before speaking, so I literally called this morning someone, forgetting it was 3 hours earlier in California, and to get some of the numbers, and they said, yeah, we just invoiced for $850,000 for a month for inmates for getting, when they leave the brick and mortar prison and go into an inpatient hospital, still actually in custody, but just in a different building. At that point, we can bill Medi-Cal for that because of the Health Pact Alameda County's program as a part of the LIP, which again, and I'm just not making a couple of assumptions for the audience, which is because California is one of the few states that did waiver in to have early entrance into the Affordable Care Act. And so that is happening. My challenge, my problem with this is exactly what was said earlier, is this isn't necessarily causing a difference in the disparities. And where the county see this as a financial boon. right? And part of that is good because there's going to be a bunch of resources for services, but there's not this great desire to improve disparities, with the exception of the Healthcare Services Agency. We happen to have an exceptional director of our Healthcare Services Agency, but just to be, the Sheriff's Department and the County Administrator's Department are like, well, we're gonna make a killing over this. Money-wise, who cares if we actually improve actual treatment? Thankfully, though, at least the Healthcare Services Agency is wanting to genuinely improve outcomes. And so with AB 109, the criminal justice realignment, we had a huge goal of enrolling folks when they come out of jail, coming out of the inmate exclusion. And so what we put in our plan, because every county had to develop a plan on how they were going to implement criminal justice realignment, was we were going to have a transition center. And it's similar to, I forget the county that I was just reading recently, that begins the whole enrollment process when the person is a week or so. Allegheny? Yeah. Allegheny County. And so the transition center is designed, it hasn't happened yet, it's designed to have probation, healthcare services, social services, and the Sheriff's Department all in the same place. And as an inmate is being processed to be released, they get enrolled in benefits, right? Healthcare, and if they need general assistance, and if applicable, AFDC, and all of the other potential benefits that they're eligible for. And therefore, you need what we call in Alameda County and many other places, eligibility technicians. And here, the details of government, right? And so the eligibility technicians union has said they don't want to have one of their eligibility technicians go into a prison. And so, but they are the only people by law who can enroll somebody in to Medi-Cal. And so those are some of the nuances of the fights. And just another funny anecdote. And so then we said, well, at least we want an ET. I always thought it was funny we called them ETs, but ET in our building, and probation. Now, social services, where their desks are literally across the street, and the union fought that. And so we have some challenges here, but there's also some discussion of trying to open that spigot up of who can enroll you, right? Because there is a online enrollment opportunity that Healthcare Services, which is in a somewhat better position to do that, can take advantage of. And so there's great opportunity. And we're seeing it happen already in Alameda County. There's a significant increase in enrollment and invoicing to Medi-Cal for inmates who go into inpatient care. The third thing, or last thing I want to say, is talking about the juvenile side. And so in Alameda County, in every county but one in California, the probation department has both adult and juvenile under its supervision. And our juvenile hall, our medical, is run by Children's Hospital, right? It's the only county where the counties, I forget the official term, that the Children's Hospital is running the medical services inside the juvenile facility. And our health suite in our juvenile hall would make you want to go into juvenile hall, right? It is an extraordinarily nice, and a lot of people come in and complain, saying this is way too nice because my kid can't get this in the community. But in fact, we can do everything there but surgery. And we talked earlier about people who say they go to jail to get medical services. Unfortunately, I've heard time and time again a young person say, in fact, the last time I was in that medical suite, a young person said, well, I got violated deliberately because I needed another dental appointment, because we have full dental care in that medical suite as well. And so one of the ways this is being mediated is there is a huge number of medical, and in fact, Robert Woods Johnson is largely helpful and responsible for this. There's many school-based health clinics in the city of Oakland, the county seat for Alameda County, which is not as nice as our health suites in juvenile hall, but they are beginning to get developed, and more young people, more students taking advantage of it. In addition to the physical health suite in juvenile hall, every unit in juvenile hall has a mental health clinician. And also inside the juvenile hall is a day treatment center. And so there is a unit specially designed for a day treatment center that has a full intensive day treatment center conducted by Behavioral Health Care Services of the county. And so there is, and the last point I'll say is there's also, both on the adult side but on the juvenile side, a significant mental health court, which we call the collaborative court. And the collaborative court, which has the behavioral health care department, probation, social services, a probation officer especially assigned to the population, and a judge especially assigned to the population. And it was interesting. The judge who started the program, who was really amazing, and he and I were both a part of the Georgetown Juvenile Reform, the Center on Juvenile Justice Reform program. But then when the judge changed, and the new judge who came in had spent the last several years doing homicide sentences on the adult side. And now he was over the juvenile mental health court. It took a while for him to adjust his thinking around a very punitive approach to attempting to do early engagement and diversion. And the true last point I'll say is what we're trying to do in the juvenile justice system in Alameda County, but also in one of my new roles working with the Sierra Health Foundation in California. We have something called the Positive Youth Justice Initiative, and one of the key components of it is trauma-informed care. And what we're trying to do is understand the trauma that young people experience that often is the cause of their delinquency. And if all the system does is attempt to address or punish the delinquency and not effectively address the trauma, then we'll never actually see a change in the behavior. And so, and most often we create more trauma. In fact, the system is, sometimes at the end of the day, the greatest traumatizer of the young person rather than trying to address and correct the trauma that they've come in with. And so these adverse childhood experiences, and there's enough studies and that talks about if you have 4 or more ACEs, of course, the health problems that could cause you later in life. And so to create screenings for the ACEs and then to address these adverse childhood experiences and not create more trauma in the young person's life. This is what this collaborative court is beginning to do in Alameda County as an example, and there's some pretty good evaluations of it thus far. So I'll stop there and take any questions in regard to the various points.
Questions?
Questions?
While the microphone's, if I can say something, just the contrast that we have between Davis County, which is very enriched.
Resource rich.
And resource rich, and a county which is like most of the counties in this country. I probably reflect what they have. It's, we call it service envy, because we know that we can't do what they do, but we can do a lot of the things that they do. But the contrast is marked. And so the one thing that smaller counties can't do is they can't just give up. They really have to continue to push on and use whatever elements they can with the resources that they have.
And just you talked about the day reporting, since you wish you can call it something else. There's one more thing. I thought I promised. But in New York, and this has received a lot of traction in the media as well, is when I was in New York, we began, and they've continued these NEONs, Neighborhood Opportunity Networks. And I fought a lot with the people there that I wanted to call Opportunity Center, but they won. They called it NEONs for branding. But there are these places where you can come in and receive, it's social services, healthcare, probation, and community-based services all in one place, and it's in the neighborhoods. And a lot of probation experiences, you come in, you check in with your PO, you piss in a cup, and you leave, and you do that again next month, excuse the language. But that's the experience for probation. And in New York, right, even if we're in the borough, like in Brooklyn, our office is in downtown Brooklyn, but if you're coming, as most are coming from East New York or Brownsville, that's like an hour schlep down to downtown to wait 2 hours in a waiting room, see your PO for 15 minutes, get a drug test and go back. And so we've opened up the first NEON in Brownsville, in Brooklyn, in the Neighborhood Opportunity Center with probation officers that want to help people to get off of probation. So I just wanted to put that example as well.
So,
Could you identify yourself, Pam?
Pam Rodriguez from Task in Illinois. So the point of this conference is about answering the question regarding disparities and whether ACA will help reduce disparities, not just health disparities, but also I think disparities in the justice system. And as I'm listening to you, it occurs to me that that one of the major shifts that has to happen in our communities and in our thinking is that the justice system is not the first place of care, whether that's health care or medical care or behavioral health care. That now that people are insured, they access services in the community first, treatment, health care, et cetera. In so doing, that will arguably reduce the need to respond to adolescent behavior, for example, as a justice system. Rather, we can respond to it as a health care and mental health system. And my question, I guess, for the California example, because you guys are out there first, one of you specifically said that California is not looking at disparities as a part of this realignment. But are there things that you all are doing that intentionally focus on reducing disparities in this realignment? Are you using new assessment tools? Are you evaluating the data differently? Is there community education around issues of access to care, et cetera? Anything like that?
Well, I'd like to answer that. Solano County, I think the issue, to answer your question, I think just because a person gets health insurance doesn't mean that they're going to access health care. We know that in our county because one of the things that we've always pushed, even before all this stuff was going on, even before the Affordable Care, is we wanted to get every kid insured, so we have funds for undocumented kids for health insurance. Access is really an important thing. I think the important issue that we have to do with disparities is the access and education. That means that we have to do the upstream work while they're in prison or wherever we can get them and educate them the importance of access. And then when we have opportunities to sign people up, sign them up so there's no break in the continuity of care. That's what happens is people just kind of don't have anything, so they don't do anything about it. It ends up costing your community way more if you don't do that upstream kind of work. So the access issue is really important in the education and doing structurally what we can to get people the ability to sign up for those kinds of programs.
And then, Pam, I would add something else. I think, David, you've been a national leader in this, so I'm not going to let you toot your own horn. I'll toot it for you, which is to rethink the role of probation. That if we look at the part of why the disparities are there is folks are going back to the same communities. It's easy to bust somebody for technical. It's easy for the PO to reincarcerate them. And so I think that part of impacting disparities is also thinking about the role of probation and parole in a different way, and thinking about that, well, this gets into the whole theory of, immediate sanctions, different ways of thinking about how we manage parole violators and probation violators. But I think from where I sit, that's really the bandwagon, David, that you've been the champion of, is thinking about probation's role as a different one, and probation's role is not simply to reincarcerate offenders.
Realignment actually gave us an opportunity for all the partners that are involved in this thing to kind of come to the table and say, wait a second, we got to get out of our silos for a second. What's best for the community to make it healthier, make it safer? Those two things are important for everybody. And so if you have everybody stopping and getting out of silos, you really have opportunities to kind of just rethink about how you're delivering your care to your population and making sure people don't reoffend and people stay healthy.
So I want to just tell one other California story to answer your question, and it's the story of Contra Costa County. So what happens in California is there's this committee of 7 folks that are set up statutorily that are in charge of distributing the state money. And the Contra Costa County Sheriff wanted to use a portion of that money to build new jail beds. And the community in Contra Costa County strongly organized itself, is that the right language to use, guys? To basically make it untenable and clear to the sheriff that he could not get a majority vote to use any of that realignment money to build new jail beds because they really wanted to go into health and social services programming. Well, what's happening in Contra Costa County right now is that money is sitting there stuck because they can't get a majority vote on their CCP, their county correctional partnership, community correctional partnership, in order to swing it one way or the other. Yep. So I've broken down the silos but I can't come to agreement yet on what it's really going to mean to make an investment in healthcare services and in behavioral services. And so I think that that's the other part of the challenge that we're experiencing in California, where we have this perfect storm of realignment, bridge to reform, all happening at a county level, that it's exposing part of the inherent tensions that have been there within county agencies. And I think Patrick's done a great job in Solano of breaking down those silos. You heard David obliquely refer to some of the challenges that they're having in Alameda County with SEIU and breaking down those silos in terms of union cooperation.
I just want to, anybody here from Texas?
Yeah, sure.
Yeah, because I had heard that Texas stopped building prisons. They just said, stop building these things.
And that's the man sitting right there.
Yeah.
Is the reason for that.
Stop building those things.
He's the reason. He and his boss.
And one of the comments I heard is because if you build them, people will come. Right. And so they had to start devoting into other things to keep people out. So one of the comments I heard from one of commissioners from Texas, and he used it for a couple other things. He says, sometimes even a blind dog can find a bone. And, you know, so Texas sometimes is looked at with disdain as far as healthcare, very independent thinking, but that was one of the smartest things that they've ever done, because basically it really forced the issue. When you build prisons, they'll just keep filling them up, and judges will feel very comfortable filling them up. But if you have the problem of overcrowding, you got to deal with it, and the vehicle to overcome the overcrowding is you got to have services that will keep people out and safe. So thanks, Texas, for that.
Hi, Allison Hamblin with the Center for Healthcare Strategies. One of the things we've been talking about with Steve and others is the time-sensitive nature of the opportunity here. When we have a population that's newly eligible for Medicaid, the potential to leverage the jails and the correctional system to engage and enroll people into the programs that they're eligible for, but really the need to do it quickly and to make sure that people actually get access to services immediately upon release. And others have mentioned continuity of care and all of that throughout. So I'm just curious if there's any lessons from the LIP experience in California, recognizing, you know, it's still early days and so forth, but in terms of making sure that those linkages happen quickly, not only enrollment, but actual access to services.
Yeah, I would say absolutely. I mean, in even answering the earlier question as well, is having intentionality around working on the disparities, right? And what I have heard too much is intentionality around being able to get money, right? And that being the big push and not being addressing the disparities. Obviously, if you have more resources and you can now serve a greater population with more resources, therefore, you could address disparities, but it's got to be that intentional, and I have not seen that as much. That would be so that's a lesson.
Yeah, my take is that it hasn't been intentional. It has been a money issue. 50 cents on the dollar when the counties have to actually pay the 100%. Well, we got this LIFT program that you can get 50 cents on the dollar. It's money, you know, and the counties have been dying for ever since the economy tanked. So it found an opportunity to bring some additional dollars. But the intentionality has to be from the people that are actually running the programs. We have to run them in a way that actually will lessen the disparities. So not yet. Not yet. It's not happening, but that's what has to happen.
Not yet.
And I think that in California there was a convergence because of the emergency nature of shifting over to the counties. It was a convergence of time and money and opportunity. I don't know if you'll get that in other states, but right now California really has to do something with urgency, and so the urgency for healthcare reform and the prisoners turned back to the county, it's a perfect opportunity. And so I'm taking advantage of that with all my partners as much as possible.
You also, if you're trying to come into a jail or an incarcerated environment, if you notice, Mr. Wallenstein said something that was very crucial, that it should be almost unconstitutional not to enroll someone. So as you implement these programs, you need to find someone who speaks jail. in order to get your enrollment in place. Because all jails, we used to laugh, we don't do intake, we do take in. Whatever the judge orders, we take that in. Right. But we interview, we examine, we question, and we get basic information. So you have to find out where in the system you can acquire great data instantly. In your pretrial services areas, your booking areas, those individuals catch that person right at the spot, and they have to do something with them almost immediately. So you need to talk to the case managers, the program managers, the wardens who have those systems, and try to fit your piece in so that you can get the information with very little angst, because there are people who are taking the information.
That's a really good point. I think Louise had a question.
Hi, I'm Louise Cohen, currently at Public Health Solutions in New York City, but formerly ran health services at Rikers and the New York City jails. So I guess my question is around the issue of enrollment, because I think that just as you were speaking about, that we've created an army of enrollers. We have not created an army of people connecting people to services. And unfortunately, since so much time and effort is spent in the enrollment process, that is much better spent in a conversation with someone about what do you need and how can I help you get it. So I guess my question is, following on your comment and also on the fairly inspirational conversation earlier this morning about data, have you all been able to make or thought about making any inroads into the idea of data matches? What we do know in corrections is who people are. And so one opportunity potentially here is to enroll people with a data match. And in fact, there is an experience in New York State where if you're in jail for a certain period of time, there's a data match between the correctional system and the Medicaid system, and your Medicaid is suspended and not terminated if you've been there for some period of time. It's just done by a data match. It's not perfect, but it's pretty good. So I guess the question is there any way to leverage this idea for enrollment? So someone who has spent some amount of time incarcerated, we know who they are, we know a lot about them. One could theoretically enroll them automatically, and then you're not enrolling them. You're actually sending someone in to do the case management work to say, how can I help you get what you need when you leave here so that we can improve your chances and longevity in the community?
So one great point. Right. So I'll end with the good note and start with the bad note. Right. The other thing,
you the bad note.
Right? No, I didn't want to keep making bad notes. But just on this enrollment piece again, the other problem that we're having around the army of enrollers are now they're also saying this exists in some counties, but in places where it's not, they're saying, oh, we also need capped caseloads of how many people we can enroll. Right.
44 a week.
44 a week, and so you've got this huge increase in eligibility. Right, and so they, of course, them saying if we cap our numbers that we can enroll, then we're going to have a bunch of more armies of enrollers and spending money there
but
instead
we're not
of
taking
connecting
that army
them.
into your jail.
No, right, and we're not going to take an army into your jail or cause future probation officers. And so that's a challenge that is overcome. On the good side, you're absolutely right. And so we did do a little bit of this in Alameda County around realignment. They did give us the roles of folks who were getting out, who were going to be on probation and not parole, and we did turn that over to healthcare, and we did a match, and we were able to say how many people were enrolled, how many people had been prior deep end users, which were a good number of them, how many had had hospitalizations, and so we were able to do some good up front, and they came out basically enrolled. There was a little bit of hiccups, as you can imagine, but that actually happened pretty well, I must say, and that is a part of the good experience of California, which I actually should have said earlier, but great, while it came out in the questions. And we also data matched with general assistance and all of the social services benefits, and that process started to have probation officers give everybody the day they came out information on all of the social service benefits and healthcare enrollment. And so that data matching actually was a great example, and it can be done with more than just the realignment population.
And again, this is part of your rethinking the role of probation.
Right.
Yeah.
Right. And so, and you literally, I didn't jump in that question because you literally said what I was going to say to the answer. But just one example of that, right? I talked earlier about what probation is. You come 2 hours, you do. And so the way we changed it in New York and in Alameda County is the probation officer is now responsible for developing this individual development plan, IDP, with everybody on their caseload. And so instead of all I do with you is drug test you and ask you, have you violated your probation? It's always wild. The person's going to say yes. Anyway, you have to develop this individual development plan. The individual development plan has 7 domains: housing, healthcare, housing, behavioral health, mental health, employment, a connection, a healthy relationship with a positive adult, and I'm missing a few others. And the probation officer must connect you with services, whichever 3 of those 7 you're most in need of. And so that's completely changing the role of probation, as you can imagine. Got some blowback for that, but we are beginning to move the market in New York, where these neons, these opportunity centers are opening. It's a part of going further with, again, rethinking probation, rethinking parole, of being able to be one of these connectors to services.
Just a real key thing that is happening both in health and social services eligibility and also probation, because we're also moving in the same direction about case managing. That isn't how they were hired. There was a different kind of job back then when they acted, and so you have a whole cadre of people that are trained a certain way. Same with my staff, over in the eligibility side. Now I want them to case manage and move people along. It's different. It's just different, and some people will survive it. But I think administratively, with people like David, hopefully myself, and a number of my partner directors, we're going to move that dial because we need to right now. But that's something that has to change in the way we do business.
No more. All right, they've pulled the curtain. With no more questions. I'd like to ask that first you give everyone on our panel a round of applause. And I would suggest you stalk them at lunch, is what I think would be the best way to get this done. On that note, I think it's about that time, and I'm going to turn it over to Mr. DuBose, and thank you all for accommodating this panel.
Okay, it's probably the best most of our time today. It's lunchtime, and if you'll go downstairs, the Thunder Grill is right to the left. Those of you that have been here before, you know the drill. If you're not familiar, the staff will direct you to where we are. We're going to be right back here in 45 minutes to an hour. 1 o'clock.